classical. So you have seen previously a different endotype, and this is different endotype. And this patient classically presented with olfaction loss. Can you see the olfactory cleft? Hello?
Yes, sir.
Can you see the
Yes, sir.
opacified olfactory cleft completely?
Yes, sir. Yes, sir.
That is classical. The access to the olfactory epithelium, any smell, any air, access to the olfactory epithelium has to be good for the smell. And here, that entire area is obstructed by polypoidal mucosa. Can you see? Yes. I don't know whether conductive or sensory. I have not given a trial of steroid. But yes, could be most likely conductive. And even sometime in the sensory loss, because of this, eosinophilic disease, majority recover once, provided you don't damage that epithelium. What happens sometimes, you have a thick mucosal, this polypoidal disease right in the olfactory recess. You are cleared from below and trying to remove from there. If you try to remove from there, you'll end up giving fibrosis. So don't do anything in the olfactory recess itself, close to the olfactory epithelium. Remove any overhanging polyp or mucosa below that, so that you don't end up giving fibrosis, and then leave it for the steroid treatment and steroid irrigation to return back to normal. If you try to do anything to the olfactory mucosa region by means of removal of the polyp or anything, you will ruin the thing. Number one. Number two, otherwise it generally comes back over the period of time as the this mucosa settles with the steroid irrigation reaching there. That's why we ask the patient to do juicing in particular position. In particular position, that so the solution should reach the olfactory area. Number two, when it doesn't come, is when this eosinophilic disease, eosinophilic cationic proteins damage the olfactory epithelium. That is one thing which can give irreversible damage to the olfactory epithelium. That's why you cannot guarantee your patient that the olfaction is going to come back. But yes, in majority of the patient comes back. If you don't damage the olfactory mucosa region, don't do anything. Even if there is a small polyp, leave it there, so that it doesn't lead to fibrosis there. And rest of the area from below, you can open up for the topicals to reach there. Now see, there is a classic sign in this patient of CCAD. Can you see this middle turbinate?
Yes, sir. Yes, sir.
Laterally directed middle turbinate because of the disease coming from medial to it. Can you see?
Yes, sir.
This is classical feature, laterally directed middle turbinate. This is middle turbinate. Middle turbinates are away from the septum, away from their natural position close to the septum. Can you see?
Yes.
And this is the olfactory disease here, main disease. See the main area. Now it has blocked the, see, it spreads laterally to involve other sinuses. Now see, it has spread laterally and blocked the frontal recess. Can you see?
Yes, sir.
And it has given frontal sinusitis. See that?
Yes, sir.
Bilateral frontal sinusitis. Secondly, this is, partially obstructed the osteomeatal region here. See this? And giving the
Yes.
maxillary sinusitis also, more on the right side, less on the left side. Has a septal deviation towards the left. Olfactory fossa. And now most important, a cell. I will show you, I will reconstruct and show you something. First of all, see the cut, size of the cut in this patient. Can you see on the left side below?
4 mm.
What
Yes, sir.
size cut?
0.4 millimeter.
0.4. See, by every jump, see my single jump, it moves by 0.4 mm. See this?
Yes, sir.
Now I'll reconstruct to three-dimensional planes and show you some important thing in the frontal, which one can easily overlook again. See, there are certain cells in the frontal sinus region which narrows the frontal outflow from anteriorly. Those are anteriorly attached cells. Okay. There are certain group of cells which are posteriorly attached, and they block the frontal outflow or narrow the frontal outflow from behind. And this has a significant impact intraoperatively while it comes to removal of these cells. Those cells which are anteriorly attached to the beak or anywhere, you can go behind those cells and fracture them anteriorly. But those which are attached behind, you can't afford to do that. Now, in this patient, there is an interesting finding which one can easily overlook, and you have to be careful. See this. Let me first show if you can pick up. Try if you can pick up. See, this is frontal sinus. Can you see?
Right, sir.
Sinus proper, intersinus septal cell, beak. So far, sinus proper.
Right, sir.
Now,
Mm.
what did you see?
Suprabular frontal.
Yes. Great. Who is there?
Shoikat, sir.
Oh, Sekat, Dr. Sekat from Kolkata. Wonderful. That is the suprabular or frontobular cell. You know, what is suprabular or frontobular? Those are the cells close to the skull base behind and try to go up into the frontal sinus. And they narrow the frontal drainage from behind. Now see, let me reconstruct and show you. First of all, let me show you this coronal one. How you can pick up from this. See, most anteriorly, no cell in the frontal sinus so far. Can you see? I am going anterior to posterior. There is no cell I can see. Can you see? That means there is
sir.
no cell attached to the anterior wall.